Hello, and a warm welcome from Great Ormond Street Hospital in London, UK, to our colleagues and friends joining us from around the world. I'm very pleased and excited to introduce the inaugural episode of our global webinar series, and it's very appropriate that this morning we're going to be discussing innovation, namely in haematology and the development of CAR T cell therapy in children. My name is Ben Marshall. I'm the Deputy Director of International and Private Care here at GOSH, and I'll be chairing our webinar today. Our guest speakers, Dr. Sara Ghorashian and Susan Farish, will be joining me shortly, and we're all very pleased that many of you have been able to join us from whichever time zone you're in. Many of you joining us today are long-standing colleagues and partners, but for those who may be less familiar with the GOSH story, let me just give you a quick overview. GOSH opened its doors on the 14th of February 1852 and has gone on to be a globally renowned paediatric hospital recognized for championing innovation and developing groundbreaking treatments for children with rare and complex conditions. We host over 60 specialties, and we are the largest UK centre for cardiology and cardiothoracic surgery, bone marrow transplant, neurosurgery, nephrology, craniofacial reconstruction, and gene therapy. We are also the largest centre in Europe for children's cancer and epilepsy. Alongside the University College London Great Ormond Street Institute of Child Health, we are part of Europe's largest academic centre for research and education into children's health and disease, helping children across the world fulfil their potential. Our Zayed Centre for Research into Rare Disease in Children is a partnership between GOSH, University College London, and Great Ormond Street Children's Charity. It is the world's first purpose-built centre dedicated to paediatric research into rare disease and directly supports our translational and patient-focused approach to research. At GOSH, we firmly believe in multidisciplinary care for our patients. Multidisciplinary teams, or MDTs, at GOSH will rarely be less than 15 clinicians and are usually between 20 and 30 people, coming from a wide range of specialties and professions to plan and coordinate treatment. Our MDT approach is an effective and efficient way for our clinical teams to gain and maintain a holistic view of the child and their family. In this session, we have two speakers joining us from our haematology department, and they will be sharing their expertise in treating patients with CAR T-cell therapy. GOSH was the first NHS hospital in the UK to successfully treat a paediatric patient using Kymriah, a type of CAR T therapy. CAR T cells have shown great promise for the treatment of relapsed acute lymphoblastic leukemia, the most common cause of cancer death in children in the UK. Before I introduce our speakers, a couple of points for your information. We are recording this webinar and it will be available shortly to view on our YouTube channels and website in the coming days. As I shared at the beginning, this will be the first of our new series of monthly multidisciplinary webinars, so please look out for future invitations. We also want to make sure that we are delivering the content that you want, so please look out for our feedback form at the end of the webinar. If you have any questions after the webinar or would like to contact the hospital, we will be sharing contact details at the end. Our two speakers today will be discussing topics related to CAR T-cell therapy for around 15 to 20 minutes each. This will be followed by a live Q&A session after we have heard from both of them. Please submit your questions or your comments in the chat function on your screens, and we will try and respond to as many as possible with the time that we have. So our first speaker is Dr. Sara Ghorashian, consultant paediatric haematologist practicing here at Great Ormond Street. Dr. Ghorashian is also an honorary senior lecturer at the University College London. And after receiving her medical degree from the University of Oxford, Dr. Ghorashian completed a PhD in TCR gene engineering of therapeutic T cells at the UCL Institute of Immunity and Infection. In 2014, she became Principal Clinical Research Associate at the UCL Institute of Clinical Health. And Dr. Ghorashian's research focuses on T-cell immunobiology and the use of cellular immunotherapies for children with hematological malignancies. And she's worked to translate CD19 targeted CAR T cells from the laboratory to the clinic. Dr. Ghorashian led the team that treated the first NHS paediatric patient with Kymriah and is part of the world-leading hematology and oncology team here at GOSH, which operates as a unified cancer centre with the University College Hospital London. forming the largest oncology centre in Europe. Dr. Ghorashian is going to be talking about relapsed ALL and when and how to refer for CAR T-cell therapy. So without further ado, I'll hand over to Dr. Ghorashian.
I'd like to thank those participating for attending our webinar series on CAR T-cell therapy and our service for this at Great Ormond Street Hospital in London. CAR T-cell treatments have changed the landscape of therapy for relapsed refractory acute lymphoblastic leukemia in children and young adults. Unlike standard pharmaceuticals, these treatments are a living drug with the capacity to grow, expand, and form memory, potentially to protect a patient lifelong from leukemic relapse. A chimeric antigen receptor is a modular synthetic immunoreceptor with a number of domains. An antibody-based binding domain extends from the extracellular surface and is responsible for antigenic recognition, whilst intracellular domains are then engaged to initiate T-cell activation. The presence of co-stimulatory domains ensures stimulation of the multiple parallel co-stimulatory pathways which are activated when a natural T-cell engages cognate antigen on the surface of an antigen-presenting cell. To create a CAR T-cell product, such as those licensed for ALL therapy, T-cells are harvested from the peripheral blood of a patient through leukapheresis. The product is then transported to the manufacturer to undergo lentiviral gene transduction. This allows the CAR to be expressed on the surface of the patient's T-cells. In the meantime, the patient undergoes bridging therapy as needed, and once a product which meets the key specifications has been made, the patient undergoes lymphodepleting chemotherapy to optimize the niche into which the CAR T-cells are received and to deplete the populations which may have a regulatory effect on CAR T-cell expansion. The efficacy of CAR T-cells targeting CD19 for relapsed refractory paediatric ALL was shown in the Eliana study of Tisagen Laclicel, the Novartis CD19 CAR T-cell product, or Kymriah. In this study, 97 patients were enrolled and 79 patients infused, while the remainder were patients for whom a product could not be made or who progressed prior to receiving the therapy. Of the 79 patients infused, 82% achieved a complete remission or complete remission with incomplete hematological recovery. Of these, all but one patient achieved MRD negativity of the bone marrow. At 2 years, the relapse-free survival amongst responders was 62%. The overall survival amongst responders at 2 years was 66%. The majority of adverse events occur in the first 2 months post-infusion. Cytokine release syndrome in this study was seen in most patients, with about half getting a grade 3 to 4 reaction. Cytokine release syndrome is a sepsis-like syndrome characterized by fever and which can progress to organ failure. It is caused by the release of pro-inflammatory cytokines as the CAR T-cells engage with leukemia cells, becoming activated to divide and expand, and they recruit cells of the innate immune system to the inflammatory response. High levels of cytokines such as IL-6 and interferon gamma are detected in the serum of such patients. IL-6 axis blockade in the form of tocilizumab, an IL-6 receptor blocking antibody, can be very effective in limiting the severity of cytokine release syndrome. In this study, there were no cases of cerebral edema reported. There were 3 therapy-related deaths, and there were 2 deaths that occurred after additional therapy had been received by patients. This slide shows the response rate of the whole cohort in the top line, and then the response rates within various subgroups treated. This includes groups which have been traditionally considered as having poor prognostic status, such as those with a high disease burden or having high-risk cytogenetic abnormalities. Despite these traditionally considered high-risk subgroups, the response rates to Kymriah across all such subgroups were very similar. But it's important to consider the real-world data that have been presented on the license use of Kymriah for ALL, as data are now available from registries such as that in the US shown here, but also from the UK, France, and other countries. I'm going to first consider the US registry data, as they have reported on the largest cohort, considering 255 patients with ALL. Here are their survival curves. On the left is the overall survival, and on the right, the event-free survival. To compare the US real-world data on the left against those from the UK in the middle and the Eliana study in the column on the right, you can see that the best overall response rates MRD negativity rates, event-free survival, and overall survival data are very similar to that reported on the Eliana study, demonstrating that delivery of equivalent outcomes in a real-world setting matches that of the pivotal study. So having understood the likely outcomes for patients with relapsed refractory ALL from Kymriah, we can now consider how best to assess a patient as being eligible for this treatment. For this, the licensed indications are patients with primary refractory disease, refractory relapse, second or greater relapse, or relapse post-stem cell transplant. Further considerations which need to be taken into account are to ensure an adequate performance status or organ function. The CSF status needs to be without obvious involvement, in other words, CNS 1 or 2 status, and there should be no bulk CNS lesions. Further, the expression of CD19 on the entire leukemic proportion is suggested, with no myeloid component or no significant myeloid component for infant ALL patients. For all these indications, it's worth bearing in mind the alternative treatments available, but outcomes need to be compared to the specific situation of the patient. For example, the predicted event-free survival of a patient in a third CR from stem cell transplantation is of the order of 40 to 50%. However, the salvage rate of those with a refractory relapse is very poor, and a CR3 can only be achieved in less than 20%. There are very few effective options for those relapsing post-transplant, unless there was more than a year's interval between the transplant and the relapse, and the considerable toxicity of a second transplant regime needs to be considered. Newer immunotherapies such as blinatumomab and inotuzumab provide a very effective platform for delivering stem cell transplantation in a relapse setting. However, it has to be borne in mind that the efficacy of blinatumomab is greater where there is an absence of bulk disease and may necessitate debulking chemotherapy prior to being able to proceed with blinatumomab treatment. Inotuzumab is very effective even in the setting of bulk disease. However, it carries with it a risk of 30 to 50% rates of veno-occlusive disease or sinusoidal obstructive syndrome seen in those patients subsequently going on to receive hematopoietic stem cell transplantation. And of course, the therapy-related mortality, effects on fertility, and the late effects of a radiation-based transplant do also need to be considered. Therefore, in the UK, our approach is to offer Kymriah CAR T-cell therapy to all those who are eligible, even if stem cell transplantation may be considered more effective because of the reduced toxicity. It is likely that about half of patients receiving Kymriah CAR T-cell therapy may need to go on to have further therapy, either in the context of loss of CAR T-cell persistence at a very early time point or the emergence of MRD level disease. However, the existing data suggests that undergoing adjunctive stem cell transplantation in this context may provide a good predictive event-free survival. For example, the single-centre retrospective data presented by the NIH group using their long-term follow-up from patients treated with the CD19 targeting CAR, where the event-free survival at 5 years was 62%. However, randomised prospective data are required. So having assessed a patient as being eligible for the treatment, one needs to consider the optimal interval from the leukapheresis from recent chemotherapy. And here are some stopping guidelines provided by Novartis in relation to the interval required from preceding therapies. Where a patient is recovering from chemotherapy, the lymphocyte count needs to be adequate and the CD3 count should be assessed to ensure the feasibility of the harvest. The patient should be tested for blood-borne viruses, including HIV and viral hepatitis. In order to obtain consent for CAR T-cell therapy, the patient and the family need to really understand the totality of the treatment. So we will discuss the whole process involved in CAR T-cell manufacture, the expected outcomes, and the efficacy in the context of failure of CAR T-cell persistence and CD19 negative relapse, which overall result in a 12-month event-free survival seen on the Eliana study of approximately 50%, assuming a product is infused. In relation to failure of CAR T-cell persistence, at 1 year in the UK real-world experience that we presented at ASH last year, about 50% of patients had lost CAR T-cell persistence, but the optimal duration of CAR T-cell persistence is not known. In terms of CD19 negative relapses, these were very common on the Eliana study amongst relapses noted, 75%, but the UK, US, and French real-world data suggest a lower incidence of 40%. The patient and the family also need to understand the toxicity of this approach, both of delivering the CAR T cells and also of the lymphodepleting chemotherapy, as well as any bridging treatment that may be required. We describe the need for close monitoring, the need for an intensive inpatient stay of a few weeks, and then the need for ongoing supportive care in the context of cytopenias, the need for disease monitoring, and our requirement to follow up the patients for 15 years for unanticipated side effects. We describe the side effects of cytokine release syndrome, neurotoxicity, cytopenias, B-cell aplasia, consequent hypogammaglobulinemia, and the need for immunoglobulin replacement in some detail. So having consented, then a patient is ready for harvest and then bridging therapy. The principles of bridging therapy are very different compared with that for the preparation for stem cell transplantation. It's important to achieve a situation of minimal toxicity, especially for patients who've been heavily pre-treated, such as those undergoing a post-transplant relapse. And one does not need to try and achieve morphological or MRD remission. It's important not to allow CNS disease to break through, because then the patient is not eligible for the infusion. And so preemptive or prophylactic CNS-directed therapy is required. One also needs to consider the potential for leukoencephalopathy developing in those who've had heavy pre-treatment with CNS-directed therapy in the context of further intrathecal chemotherapy or fludarabine-related lymphodepletion. Here are some of the regimens that we've used successfully in bridging. We've used a 3-drug induction regime with or without asparaginase, maintenance, Capizzi methotrexate, and other more intensive regimes. It's very important to consider effective antimicrobial prophylaxis and preemptive management, for example, of fungal infections if a patient has been heavily pretreated. So then the patient is admitted and undergoes lymphodepleting chemotherapy. As already discussed, this provides an optimal platform for CAR T cell expansion and depletes regulatory immune cell populations. This is with fludarabine and cyclophosphamide as a mainstay of the lymphodepleting regimes used in our hospital. We then manage the patient for cytokine release syndrome and other toxicities. Just to consider the management of cytokine release syndrome, we use the ASTCT consensus grading systems to guide management, including intervention with tocilizumab, the IL-6 receptor and monoclonal antibody blocking antibody, which I mentioned earlier. We have a very close interaction with our PICU and neurology departments to ensure the appropriate escalation of care where needed to a high dependency area. We institute a clear protocol of therapy escalation for those patients who have CRS, which is refractory to tocilizumab. And importantly, we have protocolized de-escalation of corticosteroids to try and support CAR T cell expansion and persistence in those who need to go on to have that treatment. CAR T cell related neurotoxicity, or ICANS, is less frequently seen and starts generally as cytokine release syndrome symptoms improve. There are diverse manifestations, including encephalopathy, as well as more focal deficits. A close liaison with neurology and our ITU departments is important to facilitate an appropriate escalation of care where needed. And the mainstay of neurotoxicity therapy in the absence of cytokine release syndrome is with corticosteroids. In terms of follow-up, our patients are followed up frequently in the first year, as this is when the greatest proportion of relapses occur. We also assess for CAR T cell persistence. This is through the absence of CD19 expressing B cell precursors in the bone marrow, although we are now developing tests to monitor the CAR T cell persistence in peripheral blood and bone marrow using flow cytometry and molecular means. 80% of our patients will develop significant neutropenia following CAR T cell therapy, and a similar proportion require replacement immunoglobulin therapy because of hypogammaglobulinemia consequent to the CAR T cell therapy, and all of these need to be managed. We coordinate this care through our CAR T clinical nurse specialist in liaison with the referring hospitals where possible. We also have a commitment to follow our patients up for 15 years for unanticipated adverse effects, though this responsibility can be devolved to a local CAR T cell centre as they become adults. So to conclude, CAR T cell therapy has changed the landscape of treatment of relapsed refractory B lymphoblastic leukemia in patients of a childhood and young adult age range. Ongoing work is needed to maximise the therapeutic efficacy, to overcome CD19 negative relapses, and to improve CAR T cell persistence. Coordinated care pathways with a wider multidisciplinary team are really essential for the best quality of care, and this includes our clinical nurse specialists, our neurology and PICU departments, a close liaison with our supportive care specialists such as physiotherapy, occupational therapy and psychology teams, as well as the local treating team, to deliver successful and effective care for these patients in the long as well as short term. I'd like to give thanks to the medical and nursing teams from GOSH who provide support for the CAR T-cell service, as well as the GOSH laboratories and the allied health professional teams without our service could not exist or be as successful. I'd like to answer any questions that you might have at this point, but if there are further questions not answered in the feedback session, do feel free to contact me by email. Thank you very much for listening.
Thank you, Sara. And it's fascinating to hear how this groundbreaking treatment is translating from the lab to the clinic so effectively. And I think for me, the last point that you made about the role of the multidisciplinary team is an absolute key, and it represents so well what we do here at Great Ormond Street. So before we move on to our second speaker, a reminder to all of our guests, you can submit your questions using the chat function. Please do send your questions in. We look forward to having a rich discussion after our second speaker. So without further ado, I now have the pleasure of introducing Susan Farish. Susan is a CAR T specialist paediatric nurse and has worked in the paediatric haematology department specialty for 18 years. Susan completed a Bachelor of Nursing in Glasgow in 2002 and started at Glasgow's Hospital for Sick Children, the largest BMT unit in Scotland. She then worked in Sydney Children's Hospital in Australia and King Faisal Hospital in Saudi Arabia, gaining further international experience in this specialty. Susan's been with us at Great Ormond Street Hospital since 2015 within the Private and International Directorate. Susan was appointed as the CAR T nurse specialist in 2019, and during this time she has facilitated the implementation of the CAR T ambulatory service at GOSH and developed pathways for follow-up care. She'll be presenting on the patient pathway from referral to discharge, as well as the CAR T side effects during admission and ambulatory CAR T. So without further ado, I will introduce and hand over to Susan. Thank you.
So welcome, I'm Susan, I'm the CAR T CNS at Great Ormond Street. So I'm going to discuss the nursing perspective for CAR T patients, the pathway to infusion, side effects during admission, ambulatory care and post-discharge care. So over the last 2 years, Great Ormond Street private sections had 6 patients and 2 of those were ambulatory. So Kymriah is a licensed product, it's made by Novartis, and they get manufactured in America, France and Switzerland. GOSH and Manchester are licensed to administer Kymriah in children in the UK. How it works is recognises the CD19 marker on the surface of leukemia and destroys it. So the aim is the CAR cells will continue to persist, recognise and destroy CD19 cells. So who receives Kymriah? So patients with refractory B-cell ALL, patients who are post-BMT, second or later relapse, or there's no donor option for BMT. So the first point of referral for me is when the patient is discussed in the MDT. And we ask for sponsor approval at this point. We meet the parents for the first time and we sign consents. The consultant will discuss the process with the child and the parents. Depending on disease status, we then go to leukapheresis, and this is a harvest where we get the T cells. We require a good lymphocyte count. The cell count for Novartis is specified, so the patient may require more than 1 day harvest. And the manufacturing of the cells take about 1 month. After this process, the patient goes back to the haematology team and they get bridging chemotherapy. We ask for some workup tests and a bone marrow aspirate 2 weeks pre-CAR admission. And this is to determine the disease status, if the child is high risk or low risk for side effects. The CAR T admission is minimum of 3 weeks. And there is an ambulatory option available, but they need to meet criteria. During admission, it is symptom management, side effects of the chemotherapy, side effects of the cells, which is CRS, and neurotoxicity. When the patient is discharged, we ask for weekly blood tests, we look out for cytopenia, and we do a disease reassessment in the bone marrow at day 28. We ask family to stay in London for 3 months post infusion of the cells. Long-term follow-up, there's a bone marrow aspirate at 3 months, 6 months and 12 months. IVIG support due to loss of B cells, and lymphocyte subsets to ensure B cell aplasia in the blood. So the first point is leukapheresis, where the patient gets admitted. We take viral bloods to ensure no viral infections. There's a lot of coordination between theatres, apheresis team and cell therapy lab. The patient requires a vas cath in the groin to collect cells. Chemotherapy has to be stopped as per Novartis policy. So different chemo have different times to be stopped. Lymphocyte count has to be above 300, and Novartis will collect the cells from the Ghosh lab. This admission is usually 2 to 3 nights. So they get admitted again for CAR-T admission. We do a protocol talk with the parent and the child to ensure they know the schedule. The admission is 1 week pre-day 0. So day 0 is the day of admission of cells. They receive some light chemotherapy, fludarabine and cyclophosph, and this is to reduce lymphocyte count and to make room in the bone marrow for the lymphocyte for the CAR-T cells to expand. There's 2 rest days. We ask the child to start on antifungal and antiviral medication. And the impact on the family is cost of separation and anxiety. We discussed the child in the psychosocial meeting pre-admission. The room has to be air filtered to reduce infection risk. And we offer support of school, physio, play and volunteers. So post-chemotherapy, the child's lymphocyte count will be low, so we will infuse the cells. The cells are defrosted in a water bath and we gently massage the cells. We flush the bag with a small needle, and this is just to ensure we get all the cells. There is a scent of a sweet corn smell, and that's a preservative used to freeze the cells. We have to inform the child of this taste they will experience during infusion. We ask them to drink a juice for the taste to go away. To defrost the cells is only 2 to 5 minutes. To infuse the cells, it will take up to 5 minutes, a slow bolus. We will document the times, the volumes, observations, and any adverse reaction to the preservative. Before infusion of the cells, they'll receive some Piriton and paracetamol because of the preservative. It's unlikely they will react. So post-infusion, the child has to be admitted into hospital for a minimum of 2 weeks, and this is for a reaction called CRS. CRS is your body's response to the CAR-T cells. It usually occurs 2 days after infusion, but it can start earlier if the disease burden is high. Best practice is to treat it like sepsis. We closely monitor and we use our supportive care policy. We use antibiotics and fluid support. The clinical features is very like sepsis: fever, hypotension, hypoxia, and also deranged clotting. We can use a drug called tocilizumab, and this reverses the effects of CRS. If the disease burden is high, we will do a preempt plan on using tocilizumab. When the child's admitted, the tocilizumab must be on the ward. There must be 2 doses in the fridge for every child. This is the grading we use. So most of the patients will experience CRS 1 and 2. We will discuss with the parents. It is normal for this response, and we do like a bit of CRS to know something is happening. CRS 1 and 2 is the most grading we will use. With high disease burdens, the child will experience CRS grade 4, and the parent has to be aware of the disease burden and the risk of CRS. We will inform intensive care as well of the children being admitted and the likelihood of CRS. Neurotoxicity is another side effect. This can happen in the first 2 weeks. It will increase if the disease burden is high. We will document a neuro assessment twice a week, and we encourage the nurses to do this as well. We use a grading called ICANS. The clinical symptoms can vary, and we use a grading tool depending on the age. So these are the grading tools we use. So if the child's over 13, we will ask questions and ask them to write their name and their attention. And for the babies, it's more observational. And for those children under 12, we also use more of an observational tool. This is the ICANS score we use, and the doctors will document the grading of the ICANS twice a week. So the nurse's role is to be aware of the side effects for CAR T cells, good documentation of CRS and neurotoxicity, escalate changes early intervention and support for the family. MDT approach is weekly psychology support, good play input, physio and OT, and dietitian. So over the last year, we've introduced ambulatory. This is a new approach we use to reduce hospital admission. The criteria is the child needs to live 1 hour from Great Ormond Street. There's no social concerns, good compliance. There has to be a bed reserved on the ward for emergency admissions, and the parent's able to administer medications and do temperature checks. The plan is on the protocol for the doctors and the nurses. The child will attend day reviews. There's always a high risk of readmission. The parent has to be aware the child has to be readmitted if he or she is unwell with fever. Febrile is always a first sign of CRS, and it's classed as an emergency like any other febrile episode. So the nurse's role for ambulatory plan is we do discharge planning on the first day of admission, as they will not be admitted to the hospital. Education on food, vaccinations and neutropenia, being immunocompromised, when will they return to a normal lifestyle, education on blood counts, CAR T education, and Novartis alert card. They will receive this, and this is to for emergency admissions, to let the health professionals know that they've had these genetically modified cells. So this is the ambulatory plan. We give a copy to the parents and also in the child's notes. So basically the child's admitted for the chemo, they will stay for 1 week, and then they go on day reviews for 2 weeks. They'll usually be coming twice or 3 times a week for day reviews. So for follow-up, we will usually send parents and children home after 3 months post Kymriah. We will ask them to come back for yearly reviews, but this yearly review could be done in their home country. We do bone marrow assessments on day 28, 3, 6 and 12 months. So we always look for 2 things: no B cells being the CAR T cells are still in the body, and no leukemia. The longer there's no B cells, the greater chance of lower relapse. So we want children to get to 12 months with no B cells. After 12 months, we do no follow-up after that of bone marrow assessments. There's no B cells, meaning the immunoglobulin level will be low, so they'll be started on replacements IVIG, and this is a monthly infusion. We ask for lymphocyte subsets monthly, and this is to ensure no B cells are in the blood. We have a right to follow up for 15 years post-infusion. Long-term follow-up, we do refer to immunology for the ongoing use of IVIG. And there's discussions regarding going back to haematology when the B cells return. So thank you very much, and please email any queries.
Thank you, Susan. And again, to Dr. Ghorashian for detailed insight into how this therapy is developing. And it's for me, it highlights that to truly leverage the groundbreaking innovation in the treatment of complex disease, it's important to have that multidisciplinary team and that multidisciplinary plan. So just before we open up the panel to Q&A, I'd just like to welcome our friends from around the globe. A special mention to our colleagues and partners from Wuhan Children's Hospital who are joining us. It's great to see you on our webinar. So I'll now ask Susan and Dr. Ghorashian to turn their cameras on and to answer some of the questions that you've shared through our chat function. Please do continue to contribute your questions and comments. And we'll use the time that we've got left to get through as much of it as possible. Welcome, Sara and Susan. I'd like to kick off with probably quite a general question, really, but talking about the quality of life for the child themselves. Do you think that the child, the patient, gets a better quality of life with through CAR-T therapy than bone marrow transplant? Sara, maybe you'd like to speak to that first.
Yes, thanks very much. So we find that after CAR T-cell therapy, although there are complications and they are quite severe in the short term, that they are easily manageable and that the patient rapidly returns to baseline status, which is quite good. And I think one thing that we can definitely sort of attest to is that our patients really have a very significantly improved quality of life in the months that go on from that time. And so often, although further treatment is needed, further monitoring is needed, we know that there are longer term sort of care-related issues, such as the provision of immunoglobulin and the provision of supportive care around cytopenias, low blood cell counts. The quality of life that children have is really often the best they've had since diagnosis, and many of our patients have said that to both Susan and myself. So it's really a time to focus on healing, on rehabilitating, and we try to make the most of the multidisciplinary team in that moment as well to optimise any remaining disabilities it might have from the successive complications of treatments such as stem cell transplantation and chemotherapy.
Thanks, Sara. That's great to hear. Susan, is there anything that you'd add to that?
Hi, there's definitely less hospital visits, and their immunity recovers much faster than a BMT, and they can return to school, and the children and family definitely appreciate back to normal life compared to a BMT where there's so much shielding and the medications even less than a BMT. So there's a lot of appreciation for the back to normal life compared to a bone marrow transplant.
Thanks very much, and that's great to hear. Sara, you mentioned in your presentation about the potential for ICU care. In your experience, what proportion of children would need access to intensive care?
From the Eliana study, which was delivered in the context of a US and European sort of care network, if you like, the rates of ICU admission were 50%. We are finding that with more effective bridging strategies, and we know how to tailor the bridging treatments now to reduce the disease burden, which then reduces the severity of the complications that we get, we're finding that we have about 10% or less of patients that end up having to go to ICU. And if they go to ICU, they're usually very short-lived admissions with limited requirement for organ support. Of the 30 patients that we've treated, we have had 2 patients who've needed sort of proper organ support, 4 organ support, but that's only 2 out of 30. And more usually about 10% go just for fluid management and perhaps low-dose inotropes.
Thanks very much. That's very good to hear. Susan, if I can come to you, we've had a question about education for families. Have you found that any CAR-T specific education has been required? Are there any choices for IVIG for children with no IV access?
So for the CAR-T education, it's really important that families are aware the child will test positive for HIV, and that's because of the genetic coding on the CAR-T cells. They don't actively have HIV virus, but they will test positive. So it's during the consultation with the consultant, the family are made aware of this, and it's really important for the nurses and the CNS to keep on informing the family with long-term follow-up about the persistence of CAR-T, and especially the child will test positive for HIV, but just not actively have the virus. So if they have an emergency care, the family can tell the doctors regarding this. And for IVIG, we do encourage for SCIG, so that's intramuscular once a week, and the family gets taught how to use that. And that means the child doesn't have to have a cannula, or they don't have to have a portacath. It's back to normal life. And that gets taught to the family over a few sessions with the immunology team. And it's been really well received by the families, back to normal life again. They have control when they can do it. It doesn't have to be a time specific, it can be any time during the day. So it's back to normal life and less hospital visits, which is really important, especially during this time.
I mean that sounds really, really invaluable. You know, it empowers the family, it minimises that hospital exposure for the children, and really puts the child's experience at the centre of the treatment plan. That's great. That's great to hear. So I'd just like to pick up on both of you have made a point about long-term prognosis and follow-ups. Sara, maybe to you first. What long-term problems have you seen post CAR-T therapy? Although I appreciate that this is still a very innovative treatment.
So the CAR-specific issues that we see are that 80% of our patients require immunoglobulin replacement on the basis of having low levels of immunoglobulins following the treatment, and that's an expected consequence of targeting CD19, because they will eliminate the cells that make immunoglobulins in the patient. So it's expected, but it does happen in 80% of our patients. And unlike in an adult setting where CAR T-cell therapy in the same way does not necessarily cause low immunoglobulin levels, we're definitely seeing it in 80% of our patients. So far, there's no evidence that immunoglobulin replacement actually improves outcomes, and that study's never been done. But because of the knowledge that we would cause this in patients through CAR T-cell therapy, we have also then built in the strategy for treating them with immunoglobulin following this. And that's the same as happens in the US and in Europe. So the evidence base to definitely say it's required is not there, but we've inferred that from other situations, such as immunodeficiencies, where immunoglobulin levels are low and patients are at risk of infection, that immunoglobulin replacement will be beneficial and can protect them in the longer term from infections. I have to say the rate of severe infections in our CAR T-cell patients after the first few weeks is very low, and that's even in the context of the next long-term complication I want to raise, which is cytopenias, so low neutrophil counts in particular, low below 1, certainly below 0.5 in a good proportion of our patients, and some whose neutrophil counts are even lower than that. So we do see grade 3 to 4 neutropenia persisting beyond a month after the therapy in a good proportion of our patients, about 75%. And many of them then need regular GCSF support. They need to stay on prophylactic antibiotics. So their care does become a bit more complex as a result of this. The cytopenias can persist for many months. In fact, we have patients who get to a year and are still cytopenic, but it does seem that after that first year, the cytopenias get less severe and eventually disappear. The delivery of the supportive care is a bit more complex than just being without that. But having done that relevant supportive care, we are not finding a significant instance of severe infections. In fact, most of our patients have been relatively infection-free. Having said all of that, the last year, these patients have often been shielding, and so they are relatively protected from respiratory viral infections that we would all otherwise be getting because of the restrictions that have come into place around COVID-19. But even before that, we weren't seeing a severe incidence of the sorts of infections that you might expect to get with such low neutrophil count. So that supportive care is really important. And I think it makes a difference. Having said all of that, the quality of life remains good, and we can still manage patients and they can still go back to school. So with appropriate guidance, we can still achieve that quality of life that they want to have.
Thanks, Sara. That's a very interesting observation about the last 12 months and the changes in society and the impact that's had on what we may or may not be seeing in this patient group. Susan, is there anything that you would add to that from the holistic patient management perspective?
I think it's the parents are always very anxious, obviously waiting for results, bone marrow results, if it's worked. So there's so much support needed for families in general, but waiting for results they're just super anxious. And the shielding, the COVID has kind of brought all this up again, but it's very much a multidisciplinary approach, and working with everyone, and the families really do appreciate less time in hospital and more time at home, and having more control over their treatment with so many options.
Thanks very much. So we had a couple of questions, I think, from some of our nursing colleagues who've joined the webinar. So Susan, a question for you, I think, in the first instance, with regards to HIV. Do parents raise concerns regarding this, and how do you tackle this? What written information do you give?
Sometimes at the beginning there's quite often confusion about it, because some families think they have the HIV virus. They don't. They will test positive for it because of the genetic coding. So there's a lot of explaining, and also just following up to make sure the families do understand. Obviously, every family is different. Sometimes you need to simplify it. So it's just that constant follow-up, explanation, and reminding parents 1 year, 2 years follow-up that this is still the case. The child will test positive, but does not have the virus. It's just due to the coding of the CAR cells.
Thanks very much. So obviously we've just had an international question. You mentioned that follow-up can be done in the patient's own country. So Sara, do you offer support with this, for example, via video link with clinical teams back in the patient's own country, assuming the patient can be transplanted at Gosh?
So transplant's a different scenario. I think we're mainly talking about CAR T-cell delivery here in this webinar. And transplant's a very specific scenario that would need to be discussed sort of separately. We do have patients that go on to have transplants, and we obviously coordinate that care carefully. But in relation to follow-up in country, it does depend on the specifics of what we can achieve in terms of follow-up. Obviously, it's not just seeing a patient, but it's looking at key laboratory parameters as well. So we tailor what's possible around what's available in country, and whether or not the patients are able to be seen in a facility which approximates what we need to deliver back here at Gosh. Otherwise, we'd be working with families, and if they're happy to return to us for their follow-up, of course, we're delighted to see them face-to-face and provide that laboratory support that's needed. So I think it would depend on an individual patient basis, and we would make a treatment plan that's tailored around what's available, what's possible, where it's possible to do all the laboratory tests that we would want to do, and it's just a question of a conversation and a quick visual review, then of course we could facilitate that with video conferencing where necessary. But there's a few more bits and pieces that we do in the follow-up that also are important, and so the best delivery model will be individual depending on what's available in country.
Thanks very much. And I suppose expanding on that thread, are there any specific challenges that you've experienced working with international patients?
Well, not particularly. I think we've got an excellent support system to be able to deliver the best quality of care. That's obviously easier to guarantee where it's under our physical location, but we're very flexible. And I think given the issues that we've all been facing, I think the sort of more flexible delivery of healthcare is certainly being supported on a level that never existed before. And we're all being very creative about trying to make the most of every opportunity to follow patients up appropriately, even if they don't physically come to us. So there's more technologies that are available now. The difficulty that we've had is transfer of samples back to GOSH over country borders can be difficult. And sometimes we just can't achieve that, in which case it's easier for the patient to come, because then we can get those tests done and we know that we'll get the samples that are needed. Other challenges? No, I think we've been very creative. We've had video calls, we've had photos sent back to us, and we've had the benefit of clinicians in the local area giving us feedback and direct contact with clinicians at home that can then provide the answers that we need to the sorts of questions that we would otherwise ask. And I think where the paediatric delivery of CAR T-cell therapy may be restricted in country, but for example, there's an adult bone marrow transplant centre or an adult CAR T-cell centre that when patients become 18 and older in that 15-year follow-up, we can transit the follow-up to a more appropriate facility in country where that exists. So again, we're really flexible around the delivery of care.
That's great. And Susan, I might just ask you if you've got any experience of
so I'll phone the families when they go back home and communicate via email. The families will send photos over. So I'm always in communication with the families and often email the doctors regarding blood results and follow-up. So it's been very easy, and everyone wants the best for the child, and it's been very good actually, the communication between our hospitals.
Thanks very much. I think you know, in my observation is that the last 12 months have taught us all so many lessons about how to adapt, but actually we were already in a very good place given our international relationships and our experience of managing, you know, international treatment pathways. So it's great to hear that we've been able to build on that. So I'll just, Susan, come to you with another question, if I may, around leukapheresis. And on larger children, you know, has this been done on larger children from pre-existing central lines that they have in place rather than inserting a VAS cath?
So we've always used a VAS cath, but there has been, I know for other procedures like ECP, they will use a double lumen, but specifically for our harvest, we will want a VAS cath in. Yeah, and that's just because of the flow for the machine and a better quantity of cells. So we always ask for a VAS cath.
If I can maybe comment as well, I mean, I think most of our age range obviously is children who are sort of between the ages of, well, from infancy upwards. But if you had a child who was older and in the teenage age range, then it would be possible to use simple cannulation to achieve a leukapheresis. It's just that most of our patients are in the younger age range receiving CAR T-cell therapy because of high-risk disease. It's presented early on in life. But of course, if we're treating patients in an older age range into teenagehood, for example, then it is possible to do it on a cannulation basis without the need for additional central lines. But that's sort of where our partnerships with our adult centres and the centres that deal with teenagers more frequently overlaps as well. So it does depend on the age of the patient coming to us, and we will adapt accordingly.
Understood, and thanks very much. So a quick reminder to everybody that you can submit questions using the chat function. And for those of you who may not be that familiar with using Zoom, that button is down the bottom of your screen. So please just click on that Q&A tab, type your question in, and we'll address it to the panel. And you can either submit your name or remain anonymous if you so would like. So a question has just come in. I think, Sara, I'll come to you first. When do you do CAR T? After HSCT or before HSCT?
Yeah, so this is a sort of global question, I think. So the licensed delivery of Kymriah CAR T-cell therapy for ALL includes an indication for those patients who have relapsed post-transplant. So clearly there is, well, depending on the interval from the relapse to the bone marrow transplant, it's often not feasible to consider any other therapy other than CAR T-cell therapy. And so those sorts of patients, they obviously then are being treated with CAR T after a transplant. We then have a number of indications for patients that are potentially before transplant. So for example, if you have a primary refractory patient or a patient with a first refractory relapse, and these are patients who wouldn't have had a transplant before but have an indication that we can treat them on license. Where we do that, then a patient has not yet had a transplant, and we know that of the patients going through CAR T-cell therapy, a good proportion of them have ongoing CAR T-cell persistence and will be protected longer term. But an equal number of patients, about 50%, will lose CAR T-cell persistence at variable time points before the first year. And then we have to decide whether we feel that an adjunctive transplant is required to provide the ongoing surveillance against their leukemia, given that the CAR T cells have failed to persist. No one knows globally what the right amount of CAR T cell persistence is. We've had patients with evidence of CAR T cell persistence for years, much as the original patient who was treated with ALL in 2015 at the Children's Hospital in Pennsylvania, and continues to have evidence of CAR T cell persistence to date. So we don't know how long CAR T cells need to be present, but if CAR T cells are lost within the first 3 months of treatment, then we would recommend adjunctive stem cell transplantation, assuming that the patient's comorbidity, donor availability would facilitate that. So it's a very good question. It's a question which we don't have clear answers to because the evidence base does not exist to support when to transplant after CAR T-cell therapy in relation to the duration of CAR T-cell persistence. And there may be patient subgroups for whom an adjunctive approach of CAR T and then transplant is the best way forward, but evidence is lacking. So for the moment, we do consider transplant if there's loss of CAR T-cell persistence within the first 3 months, assuming that the patient's comorbidities, performance status, and donor availability would allow that.
Sara, thanks. Thanks very much. We've had a question, and I think it's an opportunity to maybe Sara and Susan both talk through your experience of establishing the CAR T service here at Gosh. How long does it take to establish a service such as we offer? Maybe Sara, if I come to you first on that, please.
Well, so we were lucky at Great Ormond Street because we've been operating our academic studies of CAR T-cell therapy in implementation since 2013, with the first patients treated in 2014. So we've had a long experience of using CAR T-cell treatments. And obviously through the delivery of bone marrow transplantation, then we have the relevant accreditations and stem cell laboratory infrastructure that's needed. So it depends the baseline on which you're starting. Assuming that we're discussing a transplant centre that has a stem cell therapy laboratory and JC accreditation for delivering of transplants, the additional competencies required to deliver CAR T-cell therapy are then sort of defined and are quite manageable. You have to go through a process of accreditation and approval through Novartis, as well as your own in-country and regulatory approvals, and that needs to be worked through, and that will be specific for different countries, and I can't really therefore comment more widely or globally, but certainly for us, because of our preceding expertise, our existing stem cell laboratory status, the fact that we had JC accreditation, it took about 6 months to gain approval from Novartis and our regulatory bodies to be able to deliver Kymriah CAR T-cell therapy. And of course, we were the first hospital in the UK to treat a patient on the NHS with Kymriah.
Thanks very much. I think that's an excellent answer to a very wide-ranging question. Susan, in terms of the nursing care and the patient management, what was your experience of setting up the service?
So I didn't start when the service was set up. I started maybe 8 months into it, and with that, more patients were coming. Last year we've had a lot of patients, so there's a lot of teaching and education, and giving the ward more control over treating the patients and giving them opportunities to defrost the cells and infuse the cells rather than somebody coming. It gives them the opportunity. Because it's getting more popular, we're seeing more patients. So it's really important a lot of the nurses and the medical staff get appropriate teaching because the patients are coming in more frequently.
And thanks very much. And Susan, just to pick up, oh, sorry, Sarah, let's go to your comment first.
Well, just a comment to say that we've supported many other hospitals in setting up their services as well. So, for example, we had a request for training from the Dublin Children's Hospital, and the team came over to us for training. And this was when it was possible to do such face-to-face training. We've also, I've visited hospitals in the Middle East where I've been able to support their progress towards accreditation for delivery of treatment. And we've had colleagues reach out to us through emails and things like that to provide support for them. So we've been able to support many different hospitals in the progress that they make towards implementation. And so we're very happy to help support if there are particular questions that the audience want to ask in relation to their own specific situations, but that may be easiest through the email addresses that we've provided.
That's great, and it's fantastic to hear that you know, we are working with our partners around the world to share our experience. Susan, if I may, just to pick up on something that you mentioned around nursing skills and defrosting of cells. Do you have competency-based assessments for the nurses for this task? And if so, how do you maintain this?
Yeah, so it's part of a competency book, just like stem cells as a BMT, you need to be signed off, and that's you observe and then you practice being supervised, and then you're finally signed off. So it's just a once-off sign-off. And actually, we are setting up a competency book specifically for CAR T cells because they're quite different to stem cells, to defrosting them, the gentle massage. So we're setting up a specifically competency book for defrosting and administering CAR T cells.
Thanks very much indeed. So just a reminder again to everybody who is still on that you can submit your questions or indeed comments or observations through the Q&A function at the bottom of your screen. I think we're starting to see questions dry up a little bit. A question, Sara, about insurance funding for this treatment. Are UK PMIs recognising this and funding this course of treatment yet?
They are, is my understanding, particularly for adult lymphoma indications. And so there will presumably then be the relevant follow through for paediatric indications. But because I think the adult lymphoma services are, will treat many more patients than exist for ALL treatment, and then the sort of infrastructure has naturally gone to the adult CAR T cell centres first, and so there are insurance providers that are sort of following through with approvals for that. We have seen approaches made in relation to paediatric ALL therapy, but because the delivery of care doesn't necessarily always suit a UK insurance model, in other words, the shared care arrangements for delivery of care through a local hospital that's devolved. I think most patients have tended to be treated on the NHS, but for individual circumstances, it would be possible to gain approval to treat through a private setting and then deliver an insurance-based CAR T cell therapy for paediatric ALL, and the model exists in the adult lymphoma world setting in the UK.
Thanks very much. And I think, but as with any innovative treatment, we see that the insurance companies will evolve and adapt, and we know those conversations that are going on. To pick up on a thread that's coming through in the chat about the comparison between the pathway for an NHS patient versus an international patient, is there much or any difference between the treatment pathways? Sara, if I come to you first on that, please.
They're in terms of the quality of the service, and one of the reasons that we have the CAR CNS team present is so that they can support the delivery of the best quality of care across any different setting. So whether it's our international service or whether it's our NHS service, it's identical. There's support for the ward nurses to make sure that they can deliver the treatments and follow for side effects and toxicities. The medical team is the same. So there's no difference there. Our doctors circulate through both sides. The consultants attend on both sides. Our CNS team that deliver the specialist support attend on both sides. And both sides have relevant experience in terms of ward-based nursing now, because we've been doing this for some time and with a good number of patients coming through. So there really, from my perspective, is no difference. And in fact, we've been able to improve the quality of what we do on both sides where limitations exist by having that crosstalk. So, for example, we've been able to use the International Patients Platform to support services and vice versa across both sides, so that we make sure that we really have the best quality of care for our patients and the best laboratory tests, that we are innovating constantly to improve on our service. So, for example, at the moment, we are validating the ability to specifically test for the CAR T cells, which has been lacking to date, and most centres don't directly assess the persistence of CAR T cells. To date, we've used the inferred information from bone marrow and peripheral blood analysis, but we are currently validating direct measurement both by peripheral blood flow and molecular tests on the bone marrow and the peripheral blood. So we're using innovation on both sides, and that will benefit both services equally. So it really is one service delivered in different contexts.
Thanks very much, Sara. Susan, is there anything that you would add to that?
So I've worked for NHS and the international section. It's completely the same. The pathway, the care, the discharge is exactly the same. And obviously, one of the only differences is all the care is at Great Ormond Street. So the child will not be going to a local hospital. They'll come to Great Ormond Street. They'll get their clinic appointments, their tests, everything done here. But other than that, it's exactly the same care. There's absolutely no difference, which is very good. Yeah.
Yeah, thanks very much, both of you. It's really great to hear. A question come through in the chat. Obviously, we're a paediatric hospital, but this is a treatment pathway that can go on for a number of months, potentially years. What is a cut-off age for a patient entering this treatment pathway? Sara, if I can come to you, please.
So the upper limit of the licensed delivery of Kymriah CAR T-cell therapy for ALL is 25. So it's not possible to treat patients on license above that age range. You'd have to go on to an academic clinical study. In relation to the delivery of care at Great Ormond Street, in our NHS framework, we deliver CAR T-cell therapy up to the age of 13. But in the international services aspect, we are able to go up into a different age range if necessary, depending on the requirements of the healthcare provider. We also work very, very closely with our partner hospital, UCLH, and they are also able to deliver similar services. So we partner with them to deliver the care if necessary, but otherwise, if it's a specific requirement of the healthcare provider that they get treated at Great Ormond Street, we are able to go up to older children at that point.
Thank you very much indeed. And just to address one of the questions in the chat, we will be sharing the recording of this webinar via our YouTube channel and on our website. And what we will be doing is providing a link to those locations to all attendees. And the slides that you've seen today through Susan and Sara's presentations will be in that recording. So I'm just looking to see if we've had any further questions come through. I expect nothing coming through yet, but just in terms of comments that Susan or Sara, you might have thought of following your presentations and the discussion so far. Is there anything that you'd like to pick up on that we may not have covered in depth or has come up?
Thanks, Ben. I think there was one question in the questions trail, which was around the HIV positivity that exists and whether that continues after CAR T cells have failed to be persistent, and that is the case. So essentially, if the CAR T cells fail to be persistent, the child will no longer test positive for the HIV virus. The screening test for HIV comes up because of the way that the CAR T cells are generated. The genetic engineering makes use of a disabled HIV virus, and therefore screening tests for HIV are positive, but only as long as the CAR T cells persist. If there is full recovery of B cells, and therefore that CAR T cells have been lost, that trace of the HIV is lost, and it isn't seen again. The secondary confirmatory test needs to be chosen carefully in this context, and we're able to support local providers if they want advice on that. But there are certain tests that can be done to clearly differentiate the difference between persisting CAR T cells and active HIV infection.
Thanks very much indeed. We've had a comment through from one of our guests that many insurers and international sponsors still see CAR T as experimental, and therefore there are difficulties or challenges in obtaining sponsorship. What do you think, Sara, probably in the first instance, that we can be doing more of to provide information and streamline and expedite international referrals? Have you got any thoughts on that?
So in my talk, I looked at the real world experience that exists from one of the largest registries in the US. And I also compared that to the outcomes that we've seen in the real world data from the UK. So I sort of chair one of the national networks in the UK looking at CAR T cell therapy delivery. And as you can see from the slides that I presented, the outcomes in a real world setting, it doesn't matter whether in the UK, the US, the outcomes are very well matched compared to that of the pivotal study. So we really are delivering the promise, if you like, of CAR T cell therapy in the real world setting. So from that perspective, I think we've clearly demonstrated that it's no longer an experimental situation. And importantly, the outcomes are just as good when you deliver in a real world setting, which often isn't seen because often the trial situation is optimized and you get the best outcomes on a study, and then the outcomes in the real world are slightly less good. We're definitely not seeing that. There are certain differences between delivery of CAR T cell therapy now in the license mode versus during the study, and I think that related to small differences perhaps in manufacturing, and there are sort of small differences that are seen, but the big outcomes, which are event-free survival, overall survival, relapse rate, rates of CAR T cell persistence, are broadly very similar to those on study. But you're right, it is a very innovative field, and there's plenty of scope for improvement, which is why we at UCL and Great Ormond Street, and also investigators globally, are very interested in innovating further. So it is a heavy area of active research, but we need to be clear that we are delivering a licensed product when we talk about Kymriah delivery for ALL.
Thanks very much indeed. And I think, an ask to our audience that are joining us from around the world, that if you know of a forum or a group where we could present the information, the data and the outputs in order to provide confidence and spread the message that CAR T therapy is successful, then please do get in touch and let us know. And I'm sure we'd be very happy to engage with those groups. So we're beginning to come to the end of our slot, and I think I'd like to thank everybody from around the world for joining us today. As I said, this is the first of our new monthly webinar series. A big thank you to both our speakers, Dr. Sara Ghorashian and Susan Farish, for excellent presentations on truly groundbreaking research and its application to treatment, and for taking the time to answer a wide-ranging diaspora of questions from our audience. So thank you both of you for that. Very much appreciated. So our next webinar in this series will be in April, where Professor Mail Dattani will be presenting on endocrinology. So please look out for your invitation or visit our website for more details. If you have any further questions following the presentations and discussions today, or you would like to make a referral, please don't hesitate to contact us, and we'll be putting up the contact details on the closing slide very shortly. So finally, it just falls to me to thank you on behalf of the whole team here at Great Ormond Street Hospital, to thank you for joining us today. and we very much look forward to seeing you at our next event in April. Please have the rest of the day. Enjoy.